views and opinions expressed in this program are those of the speakers and do not necessarily reflect the views or positions of any entities they represent.
Good afternoon. Happy 2026.
Yeah, hello. How was everybody's holiday? Everybody's good, happy, healthy?
Oh.
I know. Same,
No, I mean, somewhat healthy, I guess.
same here. That was a rough one, man. I'll tell you.
It really never gets easier.
Yeah, it doesn't. It doesn't because, those kids, the organs take a bit of abuse over the holidays, I must say, my dear. But we're back. We're fresh. We're ready to go.
Who's going to the gym because it's 2026?
No, there's no new year, new me. No.
I work out every day
the
anyway,
people to stop because I go to the gym every day all year long.
Me
And now
too.
it's
And
packed.
the people need to go away.
Yes.
Yeah. I'm
Yeah.
done
You need
with
to
this.
go at my time of day because it's all first
I know.
responders and they're all
Ew.
just grizzled, disgruntled.
What do you mean? Ew. You catch that? That was very subtle. It's like,
Ew.
all first responders. Ew.
No, it's not. It wasn't subtle, actually. Just a lot of doctors, a lot of nurses, a lot of cops and firefighters are there, and they're all just kind of, they're very. It's just another day of the week, It's just another time of day. And then all the youngsters start rolling in around 10 o'clock. But
So, did you know you could be losing your vision right now?
no, tell me more.
And you're not going to feel anything.
Really?
No pain, no warning, just blind.
Wow, that sounds pretty scary, but it doesn't even sound like it's it doesn't start by taking what you're seeing when you're looking straight ahead, right? I mean,
Right.
it kind of comes up on the sides. So the brain sort of says, "Oh, okay, so not there. So just turn your nose and point your nose at what you want to see.
Right.
Turn your head and point your nose." Yeah.
So today we're going to talk about glaucoma, and it's a silent thief.
It
and
is.
I feel like we talked about this. It's Glaucoma Awareness Month. So
Yeah.
we were sorting through what can we talk about, and we don't talk enough about eye health, and it's connected to all chronic diseases. But early detection where glaucoma is concerned, it's everything. And we're going to zoom out and from that and talk about communication in the healthcare arena and how is that shaping the care we're able to give patients and what they're getting from us. And maybe just look at how we should reshape what we're doing and how we're treating people.
Oh, that's so true, because I think we've all been trained to just left swipe away all of our discomfort in seconds rather than actually sit through it, work through it, and resolve some things. And it's really starting to show up at the bedside, Ashley.
Yeah. So welcome back to Code Lavender 2026. We're excited.
Yeah.
This is a space where we tell the truth, protect our peace, and truly bring humanity back to healthcare.
Yeah. So Dr. Ashley Delia and Tanya, the optical nurse, your friendly neighborhood eye nerd with a nursing license and fairly low tolerance for avoidable vision loss.
Yep. And I am excited because today we're going to be joined by an absolute powerhouse in optometry.
Yeah,
which nobody really thinks about this, but she is going to join us by video chat. She is up in Canada.
Toronto.
We have snow today here in Jersey. It was way worse by me than it is down here,
Yeah.
but I
Dawn
am
insists it's a
imagining-
dusting. That's what she said.
It is a dusting. This
Well, I
is like wind
shoveled
snow.
it with a broom, so she's right.
All right. So, Tanya, you have a lot of experience with eyes, right?
yeah.
That's your former life. So tell us at the grounds level, what is glaucoma in plain English for the people?
Well, it's basically an eye disease that slowly damages the optic nerve, which is kind of where everything funnels to the back, and it's where all the information goes. It's like the highway that leads to where the vision is actually formed. And the optic nerve is kind of like a wire that sends pictures from your eye to your brain, because vision is actually a brain function.
It's cranial nerve.
Well,
I teach that part.
well,
Next.
we'll get Dr. Johar to deep dive into all of that.
Excellent.
And when the wire is damaged, your vision is actually lost forever. And we can see that among so many other things. And I'm so excited to have her tell the myriad of things that optometrists can actually see before they manifest as symptoms in the rest of the body. But back to glaucoma is the scariest part, Ashley, is that we don't feel it happening.
So why does it happen?
Well, your eye is making this fluid all the time, and it's always like flowing from one chamber to the other, back and forth. And it's supposed to drain out, actually. But if it doesn't drain properly, pressure is going to build up inside the eyeball. So just think of when you're like blowing into a balloon and it just gets bigger and bigger and bigger.
Right.
Too much pressure is going to crush that precious little optic nerve over
yeah.
time. Yeah. So think too much pressure is nerve damage.
So why don't people notice it?
Well, it doesn't hurt, first of
Okay.
all. And you really don't notice that peripheral vision loss at first because we do tend to point our nose at what we want to look at. So, you don't, and vision that you get from the side is blurred, it's contorted, and it really isn't trusted by the brain as true anyway. So and again, because it is a brain function, the brain kind of like adapts to that change in vision and just says, oh, okay, cool. So she's not getting that information properly anymore. I'm just going to, push this button and pull that switch and, like tell her, well, this is normal, until it becomes to a point where it really isn't. And you can only see what's right in front of your face. By the time you notice something's wrong, there's just so much damage that has been done that you're kind of in big trouble.
So everybody's currently booking their eye exam.
They
right?
better be.
And that damage is irreversible.
It is. Yeah. Yeah.
All right. So without further ado, we have a favorite guest, Dr. Navpreet Johar Man. She has over 20 years of experience in optometry, and she is really cool because she blends advanced clinical expertise with genuinely compassionate care. I had the opportunity to meet her on Zoom, and I just love her. I love her. I want her to be my eye doctor. I think Toronto's a ways to go, but I'll be there soon. So you never know. She does practice in the greater Toronto area up in Canada, and she works with a lot of complex vision needs, contact lenses, dry eye, ocular disease. She trained in the United States.
She sure did.
At Illinois College of Optometry, and she did a cornea and contact lens residency in the New England College of Optometry, and she was also a fellow of the American Academy of Optometry. I think what's the coolest thing about her is she never loses sight of human connection at the heart of medicine. So without further ado, Dr. Johar Man, welcome to Code Lavender. We are so excited to have you here.
Thank you so much for having me. Just a little backstory. Me and Tanya used to work together back in Toronto, and she was an optician at the eye care place that I used to work at, and we had a lot of fun back in the day.
Yeah, we sure did, didn't we?
Yeah, thanks so much for having me today.
Oh, we're so excited.
Yeah.
We are so excited. So let's jump right in, Dr. Johar, because I used to call her Dr. J.
I remember that.
I'm trying to keep it professional and polished up. If someone is listening and thinking, my vision feels fine, what do you want them to understand about glaucoma?
So like the interesting thing is for patients, like I was like, I do a lot of stats. I look at stats, and in America, we're at like roughly 50 to 60% of patients, of the population are having annual eye exams or having eye exams every 2 years. With that, most people say they don't get their eyes checked because they don't feel anything. Their vision feels fine. They can function well. However, just like how you were mentioning earlier, glaucoma is a silent disease, and there are actually no symptoms in most forms of glaucoma. So the first one is primary open-angle glaucoma, which 90% of glaucoma patients have, and that one is symptomless. The only time you have symptoms is when it's too late.
Yeah.
And if you had to tell us who's at high risk, or is there a person who might be at higher risk than others for some reason for glaucoma?
Yeah, definitely. Definitely family history is the first thing I look at. There are definitely different races that have more of a risk factor. So like African Americans, Asian Americans, over Caucasians. However, it can affect everyone. We do see that some of these numbers are changing as, you know, we live in a multicultural society. So there might be external factors because a lot of us have immigrated many, many years ago. So definitely race is one thing we look at. Family history is another thing we look at. Age, I mean, it does affect 60 and above more often. However, there is, you know, it could be any age. There's pediatric glaucoma as well.
Yeah.
So these are the things that we look at. I mean, diabetics, I mean, if your overall health is not good, hypertension, like high blood
I
pressure.
was just going to
diabetes,
ask, do you
definitely.
see any comorbidities with it?
Yeah, so if you do have diabetes is usually the big one, and you know we have a huge population of patients that are pre-diabetic or diabetic,
Yeah.
and mostly because blood flow is the issue. You're not getting enough oxygen to the optic nerve, so this can definitely cause glaucoma. Same thing with hypertension. Hypertension affects the blood vessels as well, and it's all about blood flow.
Right.
High blood pressure and the eye pressure are different. If you have a high eye pressure doesn't necessarily mean you have high blood pressure, but yeah, the healthier you are, the better it is.
Okay. And so what's your best advice to a patient who wants to advocate for themselves?
So, I mean, definitely regular eye exams. We say in a healthy individual every 1 to 2 years. And you want to go for a comprehensive eye exam.
Right.
A lot of patients sometimes mistaken just a prescription check as an eye exam. I mean, when I do a full eye exam, we're doing photos of the back of the eye, we're dilating the pupils. You want to make sure they're checking your eye pressure.
Yeah.
I mean, a lot of people probably remember the air puff test.
Mm-hmm.
A lot of people have trauma from that, but that is a test that checks the eye pressure, which is a screening test for glaucoma.
Yeah.
And there are doctors that, I mean, there's different kinds of eye exams. There are basic eye exams, and then there's ones that are more advanced, where we do more screening, we do scans of the back of the eye. And I think that is something that patients should definitely advocate for and say they want to have a scan of the eye, because regardless, there are patients that have no family history, they don't meet the, you know, the criteria of risk factors, and they can still have glaucoma.
Yeah.
Yeah.
Yeah. And
So
wherever it is, I mean, at least that's, you know, a benchmark of what we're looking at and see if it changes over
Exactly.
time. You know, if we have that photographic data,
For sure.
yeah, we can refer back and see if it's changing at all, because that's what we don't want to see is change when it comes to something like that.
When I do an eye exam, I am putting drops in their eyes, so which is a dilated eye exam, and it checks the full retina. I mean, in glaucoma, you are looking more at the optic nerve, which you can actually see without dilating.
Yeah.
It is easier to see when you dilate. And so I do a screening. So the screening is the pressure. I'm not a big fan of just the air puff. I also do, we have different machines that also check the pressure. One is tonometry, which is the gold standard to check eye pressure. And there are other machines that are not air puff, which tend to be a bit more accurate, because sometimes a patient flinches and you get kind of this, you know, inaccurate result. So that's the two main screening. And obviously you look at family history and, you know, touching base on communication. I mean, sometimes in a healthcare, you know, setting, we're so fast paced that we don't have enough time to even listen to the patient. But communication is always a key. So I think I spend more time talking in my eye exams than I do actually doing the eye exam, because the eye exam part actually is pretty straightforward.
Yeah.
And if I see, so the first thing I look is the optic nerve, the pressure, and family history. And those things kind of tip me off. And that's usually in a regular eye exam. And then I do a more in-depth glaucoma screening. I wish I could do glaucoma screening on everybody, but obviously sometimes it's not indicated. But I think doing the scans are very helpful, for sure.
Yeah. Yeah.
And I think, you know, our patients in general, they love to wait around for symptoms, something to hurt, not feel right. So symptoms, are there really any?
There are no symptoms. I mean, unless you're on the end stages and you can start bumping into things because your peripheral vision is gone. And your distance vision may always be perfect 20/20 when you look straight ahead. Just like, we just, like how Tony's saying, we just use our nose to look. And that part may be perfect till the very end. It is actually now the leading cause of irreversible blindness in the US and around the world, to be honest. A lot of people mistake cataracts and macular degeneration for those kind of things, but we're finding more treatments for macular degeneration. We're finding cataracts, is a routine kind of surgery now for if you get old enough. But glaucoma still is the one that evades us the most.
Yeah, and I imagine we're seeing them younger and younger, right, Dr. Johar?
Yeah, I think it goes in hand with metabolic disease.
Yeah.
And overall health, I think.
Yeah.
I mean, stress. I mean, I think a lot of times when we don't know what the answer is, we always relate it back to stress. But obviously, that has a component. So I think our lives have changed a lot in that sense. So yeah, we are seeing younger. I think one correlation is the need for our eyes are changing. Like people are becoming more and more nearsighted or myopic.
Mm-hmm.
And some of that is due to our environment, obviously the screen boom.
Mm-hmm.
And the higher the number that your eyeglasses are makes you at higher risk for glaucoma.
Yeah,
so
that's true with a lot of eye diseases.
Yeah, 100%. Be it
yeah.
retinal detachments, macular degeneration,
Yeah.
higher the prescription, more chances.
Yeah, that's true. Yeah. So basically, when we start noticing that our peripheral visions change, we've really missed the
you've missed
opportunity.
And then you're at a point where you may lose your license, your activities of daily living are affected, and now your life's very affected.
Yeah. And so does it typically progress to central loss as well, or do you think does it just stay in the periphery, or?
No, so if you have advanced stages, you also lose the macula. The macula is the area that controls the central part of our vision, and you will lose vision cells there as well, and you can become completely blind. Mm-hmm.
Wow, so that's a whole other situation. I mean, low vision, that's...
Yeah.
You don't want to have to go into that.
All right. So I think last question for me, it's 2026. We're all going to start it out right like we do every year. But if you had one message to any of our listeners during Glaucoma Awareness Month, what would you tell them?
So what I would say is just get your eyes tested. See your optometrist. If your vision's perfect, it's just like when you go for a physical, you may feel perfect, but you need to go for that physical. You need to go for that eye exam. So that is what my take home would be. And that try to, take care of yourself, take care of your health, try to have eat a good diet. And, we need to really put our health first and not just wait for something to go wrong and then come see the doctor.
Yeah, I agree with you. Couldn't agree more. Well, thank you so much, Dr. Johar, for coming today. We're so grateful, and we would love it if you would come back again.
Yeah, no, thank you so much for this opportunity, and I enjoyed it greatly.
We have all kinds of little eyeball questions for you.
For sure.
How much snow is there in Canada?
Oh, there was. Sorry, what was the question? How much
snow? Do you have
snow? My God, we had so much snow. It was almost 25 centimeters of snow.
What?
It was insane.
Translate that to America.
Wow.
What's 25 centimeters?
I was just going to say.
Like 10 inches. 10 inches.
Oh, wow.
Yeah.
It was almost up to your knee. I guess.
My knee's very far from the ground, if you may recall.
yeah. You're tall. Yeah. It was up to my knee. I'm short. Shorter, I would say.
So 5 centimeters. Well, have a great Saturday, Dr. Johar. We're so grateful that you took the time between your patients, and we hope to see you again.
Yeah.
Thank you.
Take care.
Take care. Bye-bye.
All right.
So that's it.
Eye exams all around.
Yeah. Well, look, I'm the one that's always on everybody for the eye exams. It's so crucial. The things that you see in an eye exam, you wouldn't believe it. You know?
Heard. Yeah.
Yeah. I'll tell you about it sometime.
Let's pivot, because I think glaucoma, it's sort of a perfect example of something else. You can have all the data in the world and still lose your patient.
Yeah.
You know, and we're starting to talk about this a lot.
Yeah, that's so very true. You can have perfect labs, you can have perfect imaging, perfect documentation, and if the patient feels dismissed, rushed, or unsafe, they simply won't follow through.
Yeah, and even just, communication, right? And we look at the Joint Commission is our national governing body that looks at sentinel events, which are just things that harm or kill patients that should have never happened.
Yeah.
And they find that it's the upper tier of 80 some percent of them are truly due to miscommunication amongst healthcare team members. So I think it's important to understand poor communication is going to fuel medical errors. It causes non-compliance from patients. It causes conflict in the environment, whether it's amongst you and I or us and our patient, their family.
Yeah.
And at the end of the day, we get burnout and we're all there.
Yeah.
And, communication's not just being nice to people. It's
No.
truly clinical.
It
Like
truly
this
is, yeah.
important.
Yeah. You need to make your patients feel seen and safe and respected and listen to them, but not just like, oh yeah, and then it's fine. Yeah. Like to listen to reply, because I feel like that is such a common theme in communication nowadays is they're waiting for that pause. You can almost see them like they just can't wait to dive in, and okay, so I guess your turn. You really do have to hear what they're saying. And there's so many specific examples I could cite, but even just being in the lab the other day, when we were, going through, Dr. Ashley has an awesome job and she has an amazing lab. And she was showing me around it the other day. And I came on this gentleman sitting in a chair and he had like one blown out pupil and one like pinpoint. And I'm like, whoa, man, that's so cool. Like what a thing to throw in there. But it's those little things, those little nuances that if I'm so busy, like looking at my watch or whatever, and I'm not looking at my patient's face, I could miss that. And we both know what that could be.
Right. And even like I do a lot of talks on communication, right? And how do we get through to our patients? So let silence be your friend. And everybody
that's hard.
Try this. Anybody who has kids, who has a spouse, just stand in the room and don't say shit.
Yeah.
It makes people so uncomfortable. They will say anything to slice that tension. So if you're just quiet, oftentimes people will let you in. They'll tell you what they're thinking. And then I think one of the biggest things we have to do is match our language to the level of the person you're talking to, not to the credentials and the letters behind your name. Nobody actually cares. They're afraid. They don't feel well. They're just going to be happy with somebody who listens to them. Look for cues. Are they afraid? Are they anxious? Are they in pain? Are they confused? They don't have a clue what you're saying. Are they ashamed? Did they not understand? Do they feel like this is their fault?
Are they in danger?
Right.
There are so many cues. Yeah, there's so many things that you can miss if you're not really fully invested in your patient. And one of the big ones is just simply presence.
Yeah. Like put your phone back in your pocket
and just be there with your patient, because a lot of times they are really scared. Sometimes this is the worst day of their life so far. Right. That's scary.
Well, and I think oftentimes it's not about how much time you're willing to spend. It's about how much time paying attention.
Correct. I agree with you so much.
And you can probably get out quicker if you listen to what somebody says. You don't cut them out, So rapid fire, what does this look like? What's good communication?
Definitely it's going to be active listening. I mean, stop charting for that 30 seconds.
Yeah, make eye contact with your patient, show your interest, have appropriate body language.
And just validate what you're hearing. Like if somebody says, I woke up this morning and, I can't see out of one of my eyes, you could just say something as simple as, that sounds pretty scary.
Yeah, and then I think
reflect.
We preach so much open-ended questions. So what's that really mean? Don't ever ask somebody a question that they can answer yes or no to.
And never.
If I say to you, are you in pain?
Yes.
That's nice. How about tell me about your pain? You can't say yes.
Well-
Well, you could say no. You could be like, yeah, forget. But truly, tell me about your pain.
Yeah.
And over time, as we get better at communication, we stop asking people yes and no questions.
Yeah. Or
So
why?
I think that's important. And don't, why is accusatory?
Yeah, we never.
Why did you do
that-
that?
I
Why
learned-
didn't you?
I learned that the very beginning of
Yeah.
nursing school. The one question, the one word you don't use with patients is why. Don't ever say why. That's one of those things. And reflection is also a great technique. So
Yeah.
you'll say back. So what I'm hearing you say is this morning when you woke up, you couldn't see out of your right eye.
Right.
And just-
And that's going to prevent like 1,000 misunderstandings, because if you're wrong, they can correct you. If you're right, we can move on with this.
Yeah. Yeah.
So I think it's really, really important to just work on this, use these techniques and practice them at home. See what people think.
In all your interactions.
Yeah. Yeah. I mean, I do it with my kids.
You
with
do.
You.
You do.
You know how annoying I am.
Well,
Yeah.
I know that I fall right into your trap when you're just quiet. I'm like, so then
Tell me more.
Oh, really?
Yeah.
Tell me a little more, Tanya. Okay.
How does that make you feel? Although yesterday I wasn't really about therapeutic questions. You know what? I had a moment. All right. So now let's zoom out a little bit.
Yes.
And I think Mo, this is up your alley. We saw this and I'm like, this is for him. I want to hear what you've got to say. New York.
Okay.
They passed a lot of laws regarding social media platforms. They now have to display mental health warning labels that are tied to features that are supposedly addictive feeds, autoplay features, infinite scroll.
Yeah.
And so they're kind of equating it to the warning labels we're seeing on other products. For instance, cigarettes, alcohol, the warnings we get with that.
Yeah.
So what are we thinking about this?
I didn't even hear any of these laws ever passed. So what is it basically? What's the goal of it? To try to limit?
Well,
I think
amount
it's
of-
to produce awareness, but I laugh. Any of these, myself included, if I'm doom scrolling and I see a warning, I'm going to be like, and I'm going to keep going. I don't know.
it's
It's like the warning labels over sensitive material type thing.
No, it's on any social media has to
Yeah.
come with a warning label now in New York, and it's called Safe for Kids, SAFE for kids,
Yeah.
and it's targeted towards people under the age of 18. And I think that the idea is that they're kind of trying to admit that the interface is doing some psychological
And there's
something on people.
there's pieces of it that are going to supposedly somehow, and I don't understand it, limit nighttime notifications without parental consent, limiting addictive features that are algorithmized. I probably just made that word up, towards teenagers.
It was a very Don King style word.
Algorithmized, yes.
Just made-
And just restricting personalized feeds.
I-
So it's an interesting concept.
I actually like it. I mean, Dawn, what show was that on? It was one of the shows we actually talked about that and the ability to limit children's access to the internet. I
don't remember which one it was
I
on.
feel like we've kind of talked about it before.
Right,
We've
it's
gotten there.
it I would not be surprised. I don't think anybody that's ever dealt with kids would be surprised that the internet is causing, I mean, even if it's not causing psychological damage, it's definitely causing them to grow up faster. It's robbing them of their childhood, stuff that we were as parents able to shield, that we were shielded from as kids. Our kids are learning at, before double digit ages.
Yeah.
And I even had proposed, I said, obviously it would be challenged in courts. I think that I feel like you should have to provide an ID to have any kind of all of your social media platforms should be verified by your ID so they can all be attached to you. And I always said that's dual purposed. It would limit the amount of just shit posting and internet bullying, and
Yeah.
because now you're not hiding behind a screen name. You might be able to use a screen name, but the server, the provider, is going to be able to find out who you are,
Right.
because again, your account is verified. And people would say, oh, well, that's an invasion of my privacy. Well, no, not really, because those accounts, you're voluntarily, like, can be basically terms of service. You want to use my platform.
Yeah.
This is what you have to do. We need to be able to verify your account, because in the event that your account is involved in a crime or bullying or whatever, we're going to be able to find you. You're not
Right.
going to hide. And then the other side of that is you're going to prevent children from having access to these services, because children don't have IDs. They're simply not going to have these profiles. They're not going to be able to get on, and you're protecting the kids. And some people would say, oh, well, that's, it's free speech. My kid doesn't have free speech. My kid, until they're 18 years old and they can put a thought together, they don't have free speech. Like,
Right.
I'm going to control what they have access to. I think, again, without it's going blind, because I really don't know the full details about what they're passing in New York. Anything geared towards protecting children.
Yeah.
I'm for it.
I can tell you that the law gives the state enforcement power. Civil penalties are reported up to $5,000 per violation. So yeah, I think that and I'll tell you something else that I was recently told that it was really shocking, that in England, and they are proposing the same change in Canada, that if you post something on social media that anybody thinks is offensive, that they can actually imprison you, charge you with a crime and imprison you, and take away your use of internet forever. I mean, I agree with kids 100%. Yeah. We definitely need to do something because their
Right.
brains are still developing. But
Yeah.
I'm just wondering, like, oh goodness.
Once you give them that power, how do you reel it in?
goodness.
How do you reel it in?
Goodness.
Yeah, no,
you
And then
know.
everybody can get offended on this, and
Well,
think
I
it's a
mean,
mess.
everybody's offended all the time now. It's
Right.
Right, and
Well-
and that's always that big debate. Like, you don't have a right to be not offended, if that makes sense. Like, if somebody has the right to offend you, and then
yeah.
you just move on, like, that's
or not. You can fart in their face, whatever you want to do. I mean,
yeah, I mean,
handle it any way you want to.
So again, there is you're spot on, where once you give the state or the government
That's my
control.
only concern. But although I'm such a huge advocate of curtailing this unlimited access that children have,
It's scary.
Yeah.
it terrifies me. I mean, and just to further into it, I mean, we were about to just begin talking about the swipe culture.
Yeah, and I think like looking at kind of like, where did they come up with this whole bill, and who was involved? And I think like from the mental health space, they talked a lot about just normalizing awareness of the psychological risk, rather than leaving a kid to sit in darkness alone and try to interpret their emotional response in isolation, because I think we know that's what's going on. And there's explicit language required about anxiety, depression, compulsive engagement in these interfaces that they're building in. And it kind of validates the common experiences that these kids are running into when they think they're just innocently on TikTok doing something, and kind of invites them to reflect a little bit. And it's also just like aligned with our mental health practices of emphasizing awareness, self-monitoring, and being aware and seeking help before things get out of control. So I believe it's well-intentioned. I think that it has a space. It'll be interesting to see how it goes.
Yeah, for sure. Yeah.
Yeah, but to Tanya's point, if they're going down the the UK road,
Yeah.
Well, no one's to say that it is.
I don't know. I'm saying, but that you always have to consider that. Like, is that what they're trying to model?
Probably
after?
not trying to, but I think when you some bells can't be unrung, and you can't
Correct.
put some genies back in a bottle.
Correct.
So it's just every solution seems to open up
Now
potential.
this is 100% passed, or is this something that
Yep.
Yeah.
It was the beginning of the month.
Uh-huh.
Mm.
Slipped right under your radar, didn't it?
I got him a
feel
Jersey
like it
resident.
slipped under everybody's radar though, because I really heard nothing of this.
Right,
until
I
it
neither
was
did I.
all over the place.
Yep.
This was passed. This is what
Yeah,
it is. And
yeah.
Wow. Good luck living in great escape from New York.
Thank God we're posting our content out of Jersey.
Yeah, I know, right?
Yeah.
Mm.
Definitely ending up locked up.
So swipe culture. You talked about swipe culture.
Yeah, yeah.
And what's that doing to the bedside stuff we're doing? And, you know, we have trained a generation to evaluate a human being in seconds, and
Yeah.
then you swipe.
Yeah.
One way or the other.
Yeah, that's
So,
right. It kind of you put so much of your value into it, Ashley, like, you know, your attraction, your worth, your compatibility, patience, and it's all being reduced to
Yep. And if it's something feels awkward or uncomfortable or imperfect or not ideal, we just
discard, ghost,
Gone.
move on, show no respect for your fellow human being, don't be honest, don't be forthcoming, don't take responsibility. It just harbors everything that I don't like about what I see in some people. Sometimes the whole if you don't want to have that uncomfortable talk, you just block. And to me, that is so disrespectful and cowardly.
Yeah.
And this is, I feel, so rampant in our contemporary society.
I'm a big blocker. Well, but wait, hear me out. I use the platform X as an example.
Yeah.
Because that's where I'm most active on. And there is I have found that a lot of the monetized accounts, it's rage bait.
Oh yeah.
They schedule these posts. They're not even sitting in front of their phone or their computer when these posts are going up. They schedule them.
Yeah.
Yep.
And it's just
an algorithm.
Like we were talking about on Mike's show, the one guy that he was talking, and I said, this guy, he says things that he knows are going to bring from both sides of the issue.
Mhm.
And whether he's getting shitted on or he's getting praised, it doesn't make a difference. It pays the same.
Yeah.
So he needs to say things. So for me, I always say, listen, I treat my social media like I would my personal life, even though social media is not real life. I treat it as I would my real life. And if I surround myself with like-minded people, I surround myself with people that are going to support me, uplift me, again, like-minded ideas, I wouldn't go and start an argument with a complete stranger on the street. Why would I start an argument? Why would I waste time online arguing with a complete stranger? It's not like suddenly we're going to have this, coming to, I'm going to change a bot's mind. It's not going to happen. And on top of that, even more crazy is I wouldn't walk down the street and jump in the middle of somebody else's ongoing, already existing argument. So why would I do that online? Online's supposed to be an escape. So like I said, I'm a big blocker, but not of people that I know, just random accounts. I'll just block them because I don't even need to see that.
That's not really what I'm talking about. It's more of a dismissive attitude towards people that deserve an explanation.
Yeah.
And I feel like it really is kind of, I know it's definitely bleeding into the bedside nursing. And it's, if they don't like dealing with a patient, well, I don't want that patient because bubbly, blah, blah. Well, that doesn't really matter if you don't want that patient because of blubbity, blah, blah, because that patient's here and you were assigned that patient. So go take care of that patient, and it's really become, there's a lot of noise about, people don't realize what nurses are hearing at bedside that we have to just let go of. And it is a huge culture shock to somebody who's used to ghosting, blocking, walking away, never acknowledging when somebody's calling them a racial name or a sexist name or whatever you want to call it, whether they're coherent or whether they are dementia. You're going to run into these patients, and you can't have that kind of a pre-programming when you go into these situations. Right. You have to just do what you got to do to patient care, to perform your job.
Yeah, our generation, especially when you talk about our grandparents, Like that, you're talking about Vietnam veterans. They, like, to your point, like, they're gonna have names for everybody.
They do.
And
Yeah.
you're not gonna like them.
No.
And everybody's grandkids and sons and daughters are sitting there cringing, like, "Dad, you can't say." Mike always says his father, when he was in the hospital, he referred to every nurse and doctor by their nationality. That was what it was.
Yeah.
He didn't know their names. He didn't
Right.
it was by their nationality. And
Yeah.
he cringed because it's like, we all know, like, that's not acceptable, but
Right.
tell that man that he can't. Like, to your point, I mean, as from a nurse or a doctor standpoint, like, you can't get all worked up or refuse.
Well, neither
like,
can you.
yeah, that's it. I mean, you just like,
Well, he
I
can.
I get worked up about anything. You kidding me?
Well, you can, but I mean, it can't impact whether you do your job or not.
Correct.
Well, I
Correct.
had a patient, like maybe, I don't know, a month ago, and anyways, I called to check on him, and he said, I got completely swiped left. And I'm like, what? And when I talked a little bit more, he was rushed. He was interrupted when he was trying to ask the physician or the provider questions. He felt talked over. He felt like he wanted to talk about one specific thing, and it is the only thing that didn't get talked about. And he's like, and I was reduced to a room number. That's how I was spoken of, room, 20 by the door, 20 by the window. So I think I think we need to recognize we're making our patients feel like we're swiping left.
Yes.
So and
To not acknowledge
probably
it is,
not intentionally, but
no,
it's out there.
no, but to not acknowledge it and not, lean into it and say, okay, we are doing this. How do we fix this? It's just going to get worse and worse and worse. And again, your patients are scared and sick. They're in pain. Their children may be ill. Like, you can't take these things personally. You don't get to say, oh, well, this person is difficult, so I'm just going to disengage.
Right. Yeah.
Or, like, you can't, when somebody starts to cry, you can't just go, oh, well, I'm going to chart now. I mean, you can't do those
No.
things,
And it's complex, like being sick is complex. Being in pain, it's messy. People are messy.
Yeah.
Fear, it makes it even more messy. Getting better can be messy. So it's the least inopportune time. And I remember many, many moons ago, one of my preceptors said to me, I was young and I was having a bad day, probably not. But she said, if you think you're having a bad day, take a look at your patient.
Yeah.
Because it's
So
the
true.
worst day of their life, even if it doesn't mean anything to you. So stop it and go take care of your patients. And that always sticks with me. I might be having a bad day, but that guy's in worse shape than me because I'm here making money and he is
sick,
doing
scared,
everything
in
but.
pain,
Yeah.
whatever, not making money.
Right.
Yeah.
So, I think to connect with our patients and human beings, you need to stay and stop swiping. Like,
Yeah.
immediately, like, stay, listen.
Even
do
just
stuff.
the buzzing of the phone is such a distraction in your pocket to have it when you have your patient,
Mhm.
like, they feel it, you feel it. And I'm not saying that nobody should carry their phone. Obviously, everybody's going to. It's contemporary times. But just again, we have to call it. We have to give it a
Right.
name. We have to acknowledge that it exists and how it's impacting bedside nursing.
Right. And then burnout, we talk all the time about that. We talk about it all the time. It's not just the workload. And Nizna, I love you. I'm no longer in the administrative seat. So rock on, Nizna, and the strike in New York City for those nurses. And anybody who wants to run your mouth and talk about how those nurses are looking for money, they're not. They're looking for safety for themselves and for patients. And I was in Queens last night and they were rocking it out in front of the ER. I was so excited for them. So keep doing what you do. You deserve better. Your patients deserve better. And, like, for real, enough is enough.
Yeah.
It really, really is. So with the burnout, it's not about the workload. It's not about pay us more. It's what happens when we take care of people, right? Like, we get burned out. And now we're managing screens, we're managing alerts, bells, checklists, do more with less. It's the common theme. So again, I feel like I have to pull that in. If anybody's on social media, I know you've seen those red and white nurses striking in New York City. And I really, really I hope somebody finally listens.
Yeah.
Because this is constant.
Yeah. We got you, brothers and sisters. And when our connection is stripped away, the work does tend to lose its meaning as well, Ashley. Detaching from it becomes our means of survival. And rather than kind of, again, I'm going to be on this a lot, naming it and acknowledging it and defining how is this impacting you? How is this impacting your patient care? We need to have some coping mechanisms because we are seeing every student come out of nursing school with anxiety. They can't test take. They don't like speaking up in class. They feel very uncomfortable around other people. And this is really beginning to become a severe problem in bedside nursing.
Yeah.
Yeah.
And I think, like, anybody know Martyr?
Martyr.
Yeah.
The movie?
No, a martyr, like a person.
Oh, of course.
I think we lose sight of the fact that this is a team collaboration. None of us outweigh the other in taking care of a patient. Nurses and doctors, we don't do the same thing, and we are not their handmaidens. We have really, really different skill sets. And, you know, every once in a while, you'll run into those nurses who martyr themselves. Like, no, look for your team. There are experts who are better than you at certain things. And I think we have to use that to help ourselves not get burnout and also to advocate for our patients. So I really think that that's important.
It is. And I mean, again, I wonder, do they even have the ability to go to their teammates and say, hey, I'm not feeling that snazzy on this?
Yeah.
They have
Well,
such fear.
I think so. I mean, because I think we're all in the same boat. And I have seen evolution of the team in healthcare. Like, doctors no longer scare people. Like, we work together with them.
Yeah.
So it's a really different environment. So I think, you know, I think it's important to acknowledge that.
Yeah. Yeah.
Yeah. And then I think on another note, we always talk about nurses in the news, and typically we find some wild, fun story and, you know, show that up. But I do want to bring up Dr. Janelle Greensmith.
Oh.
This was heartbreaking for me, but she was a 31-year-old certified nurse midwife, of course. And she advocated endlessly for maternal health, especially for Black women like herself. And unfortunately, on January 2nd, she died from complications of childbirth. And she became part of the statistic that she fights so hard against. So I think, you know, her life work, Tanya, you know, talk a little bit about what she was doing.
So she was kind of centered on reducing maternal mortality and improving care quality. And unfortunately, her passing reveals the bitter truth that expertise, credentials, and lived experiences, even as a provider, do not shield Black women from systemic risks embedded in the U.S. maternity care system. The American College of Nurse Midwives called her death heartbreaking and unacceptable, and that's to put it mildly, characterizing it as a profound failure of the systems meant to protect birthing people.
Yeah, and I think, like, I've been talking about this for years. I've done so much work, but I think to understand why it happened, it has to get placed in that broader context of Black maternal health disparities.
Yeah.
They're there. The latest public health data that's available in the United States, we know that Black women in this country, which is an industrialized nation with a really robust healthcare system, they are 3 times more likely to die in childbirth than white women. Even after we go in and do all of our statistical voodoo, we can adjust socioeconomic status levels, education levels, professional expertise. They are still 3 times as likely to die as a white woman who isn't equal to them on intellect, socioeconomic status. And I think we have to understand that this is social determinants of health. It's systemic racism.
Yep.
It is built into our healthcare system. It is learned, hopefully unintentionally, but it is learned as we learn to become healthcare providers.
Yeah.
So, when I saw this, I can't not talk about this. I
Well,
think
I
she
mean,
needs to be recognized.
It's also the disparities are not biologically determined. I mean, there's no reason why this should be happening
Right.
at a rate of 3-1. There's just there's no justification for, and it's like you said, I mean, we have a very robust healthcare system here in America. Not okay, and we're calling it out.
Yes.
Yeah.
So, I think we need to continue the work that we've done. And when you look at Black maternal morbidity and mortality, the Black infant morbidity and mortality is actually worse of a detriment in this country. So that should not be lost either. But I think, recognizing her loss and focusing on her legacy should be the challenge for everybody to act, especially those of you who are taking care of women. Women who are able to be pregnant. Forget if they are or not, start talking to them before they are pregnant. And make sure, we're doing a lot of cool stuff with community doulas. And, we know statistically women want to be taken care of by women that look like them, that they can identify with. So I think diversifying our workforce is important.
Yeah, and that's a great point as well, though, Ashley, that, we should take advantage of every opportunity that we have pre and postpartum to talk to our patients.
Yeah. And I think we need to, as providers, and we talk a lot about this, we do a lot of simulation, but check yourself. You will be aware when you make an assumption and when you make maybe a just inference because of what you think. So be aware of your biases. We all have them.
Yeah.
And do better.
Yeah.
So I think this is good for the start of 2026. I want to land this plane with big takeaways. So glaucoma.
Okay. Glaucoma.
Yeah, you're not going to feel it. You're not going to feel it. Who's going to the eye doctor? Monday's a holiday.
It is actually crazy that this would come up now, because Stacy's going through something with her eyes now. We don't even know what it is. She's having trouble seeing out of her right eye.
Mm-hmm.
When they put I guess there's a patch or some kind of card that will only let you see through a pinhole.
Yeah.
She sees perfect.
Okay.
So it is something peripheral. When she had gone for a scan, to her regular, I guess that's optometrist, she panicked because she made it sound like her lens was floating, whatever that means. We didn't like what. So she got her right away into another doctor.
Mm-hmm.
The other doctor sent her for an ultrasound, which she went for on Thursday, I think. And that doctor didn't see anything that. I guess they put the water on the water pack on the eye, did the ultrasound, and he didn't see anything that the first doctor saw. So now she doesn't even know what it is. So she was back at the other doctor this morning. I'm going to find out what. And they're bouncing her all over the place. And now, so Stacy's panicking now because now she thinks, is it not an eye issue and it's a brain issue?
Right.
That's what's and because she's got MS is in the family, and she's like, well, could I have had, a mini stroke and not even realized it? Right. And now have this eye damage. Because again, she didn't know. I'm curious to see what
it was presenting with visual disturbances.
Yeah. She's having trouble. She's getting headaches, but the headaches she's attributing to the eye being, having trouble seeing out of it. Almost like this,
almost psychosomatically induced.
Right.
Yeah.
So like the nausea and the headaches being associated to that.
Yeah.
But again, she doesn't know. She's lost a boatload of weight. So, and I don't think they've ever really adjusted some of her meds. So she's like, could I have had a stroke relating to extremely low blood pressure? Like her blood pressure has been ridiculously low sometimes.
Yeah.
So I'm curious to see because I told her, I said, you got to go back to that first doctor and you got to say, all right, circle again for me what you saw that made you panic to get me to this other doctor right away.
Right.
Because again, that guy that took the ultrasound, so I don't see any of that.
Yeah.
So yeah, but that was, I forget what there was two things. There was the one with the lens floating, and then there was another one where something was leaking. I forget what the name of that was. It was an eye disorder. I'll text her while you guys are finishing up and I'll get the name of it. But yeah, if something was leaking, and if it was that one where something was leaking, that was one that could cause like blindness, like
Mm.
almost instantly. So that's why I think she panicked.
Yeah.
But then the other, it was like, no, your lens is float. What does that even mean? Like, this
That's
is
the
wild.
First time
So-
I've ever heard that.
Yeah. Yeah. So I've been now peppering her with, crazy eyes from Mr. Deeds, the guy that has the eyes. I think Buscemi played him with the eyes floating around the head. I've been sending her those. I'm very thoughtful. I'm very supportive.
That's really sweet.
Yeah. I like to think that I'm a supportive guy in that way. Yeah, but it's wild that you guys should be talking about that, because that's ongoing as we speak. And I'm very curious to see what the doctor said this morning.
Well, and I think like generally, like we don't talk about eyes at all to patients. Like never once have I seen a patient in the ER and said, you should really get your annual eye exam, but you really should.
Yeah.
Everybody should go and get an eye exam. It's going to protect your sight. And kind of to your point, like, Stacy's thinking brain, this, that, well, yeah, like it might lead to the pathway of something that otherwise might have festered before it caused enough symptoms. So really, really important, especially if you have any comorbidities, diabetes, hypertension, family history, racial risk factors, age, sex sometimes. And the other thing of it is I've done a lot of reading because this intrigued me. Anybody who has used steroids for a long time, and yes, there are some chronic diseases where we prescribe, but for the most part, like anabolic steroid use in athletics, they lead to a lot of blindness.
Yeah.
So
Dawn, you're in trouble.
Yeah.
Me, no.
So, be aware. And then communication. I think, everybody go home and don't say anything to anybody and see what kind of dirt you get.
I love it. I love it. She does do that all the
I
time.
do it all
have
the time,
to tell you.
all the time.
She really does.
Cops do the same thing. You just sit and
Oh, you do.
you just sit.
Dirty.
They'll talk, especially, car rides. And that's, again,
Rides.
I'm not, I'm not giving away trade secrets. It's all spontaneous utterances.
Yeah.
Don't ask them any questions.
Just
sit nice and quiet in the ride. And you're 100% right. They can't help but talk. They're going to talk about something.
Because they're so nervous.
Yes. And then they just start rambling. Yeah,
Another funny thing that they do, my girlfriend told me this, Jennifer, this kills me. She said, so many times when she was doing mug shots, they would be like, they'd smile or they'd say to her, should I smile? And she would be like,
they do a lot.
Are you happy?
They do a lot. And then another thing that
If you're happy, I guess.
hypothetically cops do is if you ever do get fingerprinted, sometimes if you look like somebody, that might end up being your alias. Hypothetically, you won't even know that. But if you look like somebody, like, you know what that person looks like? So, that's now your alias. For anytime you ever get, don't look at me like that. I didn't say, I'm saying as things I've heard, hypothetically. I'm just
saying.
Let's everybody sit quiet and see who breaks first.
I know who won't. Here I am.
no,
I'm already talking.
No, we're already.
I don't even think I stopped.
You didn't stop. Nope.
I'm the
All
easiest one to get to confess to anything.
So happy 2026.
Yes.
We'll be back next month, but seriously, take care of yourself. Get your freaking eyes examined, and we're going to talk a lot about preventative care. We're supposed to be practicing on a preventative model, but we're not doing a great job of it.
Well,
So
that's
I
a
think
great
just
step
bringing
forward
awareness.
towards it is,
Yeah.
doing just using your multidisciplinary and start telling them to get to their eye doctors, get it looked at, it totally is screening.
I heard too with that. Well, okay, my mom works for a optometrist. It's actually a big practice. They have 5 offices. She's worked there for since I was 12. But I guess you can actually determine a lot of diseases by looking at the eyes.
Oh God, yeah.
Kidney problems, all sorts of stuff.
Yeah.
So people think it's just
Cholesterol.
vision, but it's not just vision. There's a lot of times they're
Hypertension.
like, yeah, I think you need to go see your doctor for that.
Oh yeah, you'll
Yeah.
see like a lumpy looking optic nerve, or your disc can look too pale, and that can be an indicative of MS.
Right.
Banking, the veins folding over each other, that's a sign of hypertension. You can actually see a ring of cholesterol around some people's eyes, and you've seen it. I guarantee you've seen it. It's called arcus senilis, and it's just like a white ring around the
Do I have it?
no.
Okay.
No, you've seen it though. If I showed you a picture of it, you go, "Oh my God, is that really cholesterol?" Yeah, it totally is. It's wild. But yeah, you can see a lot of stuff looking in people's
Is that
eyes.
high cholesterol, low? Like, what is that? Like, how do you? Do I have
That's
Arcus
pretty. No, I'll show you a picture of it. No, it's like if you see it a lot in people that have brown eyes. Their eye looks brown here, but then there's a ring of like white or yellow that goes to like the whole circumference
Yeah,
of
we
the
gotta take a
iris.
picture of this.
Yeah, it's cool.
That's wild.
Yeah, it is.
All
Yeah.
right. Well, happy January.
Happy January.
See you
Happy
next
January,
time.
guys. Get home safe.